Hello and welcome to the Neurology Nuts and Bolts podcast, a podcast all about constructing your career in neurology. I'm your host, Sara Schaefer from the Yale School of Medicine and the founder of this podcast. Today, as part of the GME series, we will be speaking to Dr. Bryan Carmody, who's a nephrologist, not a neurologist, a nephrologist at Children's Hospital of the King's Daughters in Norfolk, Virginia. Thank you for joining us today.
I'm very excited to be here.
So today we're going to be talking about how residency slots are funded. This is a very complicated topic and something that I'm hoping Dr. Carmody can enlighten us about. Let's start by going over the structure of GME slots in the US and also the stakeholders that are involved. Who determines slots' existence? Who are the stakeholders? There's the ACGME, the local GME office, CMS or Centers for Medicare and Medicaid Services, the hospital system, obviously. How does that all work?
That's a good question. Yeah. So if you just wanted to, hang out a sign and open a residency program, I guess you'd have a few different barriers you'd have to overcome. I mean, first of all, you'd have to have an accredited program. And so whatever specialty you were trying to train residents in, you'd have to meet the ACGME's core standards and then the program's, the specialty specific standards for your program, in terms of your resources and your faculty and your patient load and all those things. But then, residents these days, at least, they want to be paid. And so you would need to have some money to pay your residents. And that would require some discussions with your hospital because although there are, as you suggested, there are generous federal subsidies available for many training positions, ultimately the hospitals are who pay resident salaries and pay for the benefits and pay for all the structural supports that residents require. So you'd have to work out the dollars with your hospital if you wanted to do this.
All right, so let's talk about the history here because this goes back 100 years or so. What is the history of resident salaries and funding? Can you take us back to the early 20th century? How did the origins of Centers for Medicare and Medicaid Services, or CMS, play into the changes over time? Let's have a little history lesson.
Yeah, let's do it. Because really, I think when you look at the history, I mean, honestly, it's the only way to understand how some of the sort of strange and quirky things that are in place now came to be. So I guess you got to go back to a time where, residents really didn't get paid. And that wasn't that long ago. I mean, if you go back to the 1800s, I mean, that's where the term, of course, resident comes from, is that was your compensation, was you got trained and you literally lived in the hospital or on the hospital grounds and you had your room and board taken care of. And that's what residents got. There wasn't any sort of market determination or price discovery of what a resident was worth. That was the sort of the system as it existed. And then, with the advent of sort of more modern residency training, at Johns Hopkins in the late 1800s and early 1900s, we sort of had a system, but still residents didn't really get paid. I mean, they might have gotten a small stipend to buy some books or, sundries. But again, the primary deal was you're receiving this training that's going to make you not just a general practitioner who hangs out a shingle and hopes people come in, but an elite physician who can get a job at a hospital, who can teach at a medical school, by coming to this residency training program. So the bargain was you're getting training and you're getting room and board and maybe a little stipend, but it wasn't conceived of as being a salary. And gradually what happened is as hospitals expanded and residents provided an increasingly important component of the hospital's workforce, more hospitals wanted residency programs, and the physical space available for resident physicians became more limited. And so starting in Boston and New York, hospitals began to offer trainees the opportunity to not live inside the hospital and instead get a stipend that would cover the room and board that they would have received had, the hospital had the capacity to offer them that. And of course, that was nice also because a number of trainees, unlike in the, Halstead days, for instance, they're married. They had families. They didn't want to live inside the hospital. So anyway, gradually Um, I guess the big turning point is when, like with many things in American healthcare, is when we started to have insurance. So, in the period before and during and after World War II, insurers started to pay a small sort of add-on fee to the fees they would pay hospitals for the residents who were providing care to their beneficiaries. And so that kind of gets us into the 1960s, which is when really the critical moment happened. And that was the Social Security Act amendments of 1965, the Medicare Act. So the political history there, of course, is interesting. Social Security had been around for a while, but it wasn't until the 1960s with, Lyndon Johnson's Great Society and you had this Democratic, landslide election in 1964 that you had the political machinery to put in place this national healthcare systems. So it was added on to the Medicare amendments that Medicare should pay a portion of resident training, just like some of the private insurers had been doing, to compensate for the fact that, Medicare beneficiaries, if the hospital is providing care to them, then Medicare should pay its fair share of that. And so it came to pass that Medicare agreed to fund a proportionate share of its beneficiaries, the costs borne by the trainees at those academic medical centers. And that subsidy persists to this day as what we call direct GME payments. So DGME, if you hear that term. So those are funds that flow through CMS or Medicare to hospitals that train residents, and they're intended to support the direct costs of training residents' salaries, residents' benefits, the program director's time, whatever administrative supports they need, accreditation infrastructure these days, all those things. Those are the direct costs of having residents.
All right. And then there are some additional kind of legs of this that came on in the subsequent decades, right? Medicaid started being involved in some way. There was something for children's hospitals where, of course, there are not Medicare patients. Can you talk a little bit about that?
Yeah. So starting with the Medicare Act, we had DGME payments. And through the 1970s, there were a couple of things that, I guess nationwide, Medicare became more and more and more expensive, and the economy slowed down. And so through the 70s and into the 80s, it became a real cause for concern about how are we going to trim costs in Medicare. And along with that, on the graduate medical education side, when you have a subsidy that will pay hospitals to train residents, every hospital has an incentive to train residents. And at a certain point, that needed to be pared back, which I guess is something I'll come to first. But I guess we should do the first chapter, which is in the 1980s, under Ronald Reagan, there was a reform to the way that Medicare paid hospitals. So it's sort of hard to imagine this these days, but in the early days of Medicare paid hospitals whatever was reasonable and customary. If you stayed in the hospital for 30 days, whatever the hospital spent on you, they just sent the bill to Medicare and Medicare paid it. And similarly, that's how the DGME payments were calculated. Whatever was being done, whatever was reasonable and customary. So the provision of these DGME payments sort of froze in time what hospitals were providing residents in the 1960s, with this subsidy. But anyway, in the early 80s, that's when we had the first round of prospective payment system, a PPS, Medicare PPS. And that system persists now in various iterations. But the general premise of it is that no longer will Medicare just sign a check for whatever you provide. Medicare will pay a certain amount based on the patient's, DRG, diagnosis related group. So, you get admitted with pneumonia, the hospital gets sort of what the usual expected expenses for that would be. And so a system like that changes the incentives for hospitals. You no longer have the incentive to just do more stuff and bill more and more. You, in a way, have an incentive as it's designed to do less so that you can keep more of that DRG payment. So teaching hospitals were very concerned about this. And because from their standpoint, although residents provide valuable services, they don't provide the most efficient care. I mean, maybe they're ordering unnecessary tests. Maybe they're, by virtue of the hospital even training residents, you attract sicker patients that are going to be harder to care for. And you're not going to be left with as much of these DRG payments. And academic medical centers were concerned that if this measure passed, that it would harm them financially. And so they advocated, and Congress agreed to provide an additional funding stream, and that's called indirect medical education payments, so IME. And again, this funding stream persists to this day, and it's intended to subsidize the indirect costs, the inefficiencies that might result from having residents involved in care. And those things are hard to measure. I mean, they're indirect, but it empirically seems to be true when budget organizations have looked at it that these costs seem to be overestimated with the current funding system, that IME subsidizes these much more than might be empirically justified. Let me jump back to the DGME. So I mentioned a moment ago that we had a problem where with this incentive system, hospitals had an incentive to train as many residents as possible. And in a way, maybe that's a good thing for society. I mean, to the extent that training residents and building a physician workforce is a valuable public good, we want to have that incentive. But it gave hospitals maybe a little too much incentive as long as Uncle Sam is going to cover the cost of all their residents. Why wouldn't you want to have as many residents as you possibly could? And this creates sort of an uncontrollable expense. And so in the 90s, that came to a head. And as part of the Balanced Budget Act of 1997, Congress placed a cap on the number of residents that it would be willing to subsidize in this manner. It froze at 1996 levels. Positions that were in existence at that time and were being paid, that's how many residents Medicare was going to fund. And so, of course, it doesn't keep hospitals from having more positions. You can have more positions, but you won't necessarily have a CMS subsidy for them. Now, for hospitals that weren't training residents in 1996 or 1997, you can still get residents, and there's a whole game to doing this. Your cap gets set by the residents that you train in the first 5 years of existence. And so if, like we were discussing at the beginning of the show, if you wanted to start a residency program, it's much to your benefit to train as many residents, to build the program as rapidly as possible over the first 5 years, because once your cap is set, it's set in perpetuity. And so there are a number of consultants that will help you and your hospital do this, get your residency program off the ground with a big bang so that you can train as many residents as possible and get as generous of a cap as possible so that you'll be entitled to these federal subsidies moving forward and not have to fund those residency positions out of other operating revenue streams.
So is this 1996 cap like a set value nationally? Is it by state? Is it by hospital? Is it by residency program? Like, imagine if a new hospital has new residency programs, are they taking from somebody else's allotment in order to add their residency and meet that cap within the first 5 years? How does that all work kind of on a national level?
It's a complicated thing. So every hospital has a certain cap. It is possible for hospitals within a certain system to transfer positions among each other and get them paid by Medicare. But every hospital's per resident amount and the number of full-time resident equivalents that they have is variable. And none of this, I guess I should say, none of this is very transparent. I mean, there's a lot of problems with this system, but one of them is that exact figures are hard to pin down, even for people in the government. There's not any sort of broad transparency about that. And it's hard to imagine that policies work better in that kind of environment.
All right. So let's talk a little bit about, you talked about how the funds are calculated. Let's talk a little bit about where those funds go and how much money we're talking about. And then what I'd like to talk about is what the options are for a hospital system should they be at their cap and beyond 5 years and they don't have the possibility of that government funds flow. So what is the funds flow from CMS to the hospital to the resident? It doesn't go directly to the resident, right?
Correct. Yeah. So the money goes to hospitals. And I guess that's another thing that, as we go through all this history, I mean, like I said, you can see how things got to be the way they are, but certainly this is not a system that anyone would design from the bottom up. No one would say, we want to subsidize resident training. How are we going to do it? Oh, we're going to make these two funding streams and we're going to make per resident amounts and we're going to have unusual constraints and all these different historical freezes and, different adjustments for inflation at different times. Nobody would ever come up with such a system. Okay, so the DGME payments go directly to the hospitals. That's a hospital asset. It goes directly to the hospitals. The IME payments are actually just tacked on to each of these DRG payments. And again, there's some math that's involved based on, there's something called the intern and resident to bed ratio. And based on that and the proportion of Medicare beneficiaries that you care for, your hospital gets a higher DRG payment for each of those things. So each of those charges, when the hospital is reimbursed for each of those discharges, there's a little bit more money there than if the patient had been discharged from a hospital that doesn't train residents. So all these dollars go to the hospital, and of course dollars are fungible. And once they're thrown in a pot, it's hard to say that one comes from one place or another. But and again, the amounts that hospitals get are highly variable. But you can ballpark it to some extent. And so to give you some real numbers, I looked these up again just a few minutes ago to remind myself, but in 2020, which was the last year for which I could find reliable data, CMS paid around $4.5 billion for a little over 88,000 resident FTEs for DGME. So if you just do the basic arithmetic, you end up with around $51,000 for the average per resident FTE DGME payment. So $51,000 for that. And then for IME, it's actually quite a bit more. For IME, there was over $11 billion for 98,542 resident FTEs, which works out to be around 118,000 per resident FTE. So, you total it up, it's around 169,000 on average. And again, the accounting here gets a little bit tricky because a resident FTE is not the same as a resident head count. I guess there's lots of little funny things here. I mean, I guess we should sort of set out some of them. For instance, while you're a resident, you could conceivably count as one FTE towards your hospital's cap. When you're a fellow, you count as 0.5. Once you're board eligible in a primary specialty, you only count as 0.5 for purposes of determining your DGME funding.
Okay. We are going to do a separate episode on fellowship funding, which I think is a whole nother ballgame. But just for our listeners, FTE is full-time equivalent. So a 1.0 FTE means that you're a full-time employee. It's the same as faculty.
Yeah. So it's a lot of money that flows into hospitals for this. Some costs of residency training are easily calculated. And like I mentioned, I mean, salary, very easy. Residents' benefits, easy. The program director's salary, easy. What's harder to ascertain are all the indirect effects. I mean, how much infrastructure is required? How much does that cost? I mean, to keep up the accreditation and stuff like that. And then, another one that's sneaky is certainly in most ways, I think residents add value to care. They allow attendings to bill more, but there are certainly other ways in which they slow faculty efficiency. I mean, when you're teaching rather than just out there generating RVUs, or in clinic, for instance. I mean, a single attending might be able to grind through patients more quickly than when they're supervising residents and having to see each of those patients themselves. So things like that are harder to put a dollar amount on. But in reality, I think it is clearly the case, given that even as constraints have been placed on the amount of federal subsidies that go to residency programs, the number of residency positions and the number of residency programs continues to grow. And hospitals wouldn't do that if it weren't on balance. Every medical center is different, but on balance, it's a financial winner for hospitals.
Is an individual hospital going to know how much IME is coming into the system if it's tacked on to every hospitalization billing situation?
Yeah, hospitals do know this. Even though it's complicated, they know it. And I'll tell you one way that comes to mind that shows that they know it. If you think back to COVID, there was some policy advocacy from AAMC and other organizations that represent and advocate for academic medical centers about the unintended consequence of expanding the number of beds would be a reduction in IME payments. Because I mentioned that one thing that goes into this formula, which you can look up, but is the IRB, the intern and resident to bed ratio. So the more beds you have, the lower that ratio becomes. And there was concern that if you open temporary increased beds that are eligible, that would count into this formula, that your IME payment was going to reduce. So to make that argument, especially as rapidly as it came out, there has to be some awareness of this, the hospital boardroom of what these numbers are going to look like and, how they might be impacted by different changes.
That's so interesting. All right. Well, okay. So, say a program wants to increase their complement, right? And they get approval from the GME and the ACGME, and then they go to the hospital and say, we need funding for an increased resident. So, if a hospital system hasn't yet met their cap, they might be more likely to say yes to that, right? Because they know that they'd be getting DME and or D IME and DME, is that right?
DGME, yeah.
DGME funds for that resident. But if they have met their cap and there's no possibility for increased funds from CMS, what are the options?
Well, I think probably the argument you would want to make to your hospital, because again, I mean, positions can be funded out of the hospital's operating revenue. And so what you want to argue is how that resident is going to increase the operating revenue in a way that more than offsets, the add-on cost. And I think most of the time that can work out. Now, it's not inevitable that it works out. I mean, you have to make the argument. You can imagine, I mean, suppose I have a hospital and it's staffed with residents, but I want more residents for whatever reason. Maybe I want the call to be beat. I want to have 365 residents so that every resident only has to be on call one day. How about that? Well, if I did that, I could go to the hospital. I could make that argument. I could say, I want everybody to be on call just one night a year. That's it. Can we have 365 residents? That's not a financial winner because there's no extra work that's being done. There's no extra bills that are being generated. As many patients as were being seen in that hospital and as many bills as were being dropped, it's now no different. It's just being split among more residents. Now, on the alternative, if I say, I work in the emergency department and we are having to divert patients to other EDs who otherwise would have been admitted here and they would have gone to the cath lab or they would have generated some expensive inpatient bill, but we're having to divert them because our ER is so overcrowded that we can't move the pile and we need another resident. And if we did that, we would have this many more admissions or we'd have this many more. That's more of a winning argument. I think if you're in that situation, that's the case you want to make is, as I said, dollars are fungible. And the operating revenue that goes to support an additional resident could be more than recovered depending on how that resident is going to function and the value that they're going to provide to the system.
All right. So a hospital can look at the math and decide that they just want to fund a residency position. What about other options that sometimes we use on the fellowship side of things like philanthropy or industry or even resident billing to partially fund their own training?
Right. Yeah. I mean, all of these things are potentially legitimate options. If you wanted to have a car wash or a lemonade stand or something, I mean, certainly you could do those things too.
A bake sale.
Yeah, right. I mean, again, we sometimes, I've said it several times, but I think it sometimes is worth reminding because when you get steeped in the world of academic medicine, sometimes, and it's true, some dollars are through various regulations earmarked for something or other. But in general, like I say, I mean, we might have ideas of how we want to spend our dollars, but dollars can be spent on one thing or another just as well, so.
Okay. All right. Well, you mentioned that nobody in their right mind would build this system the way that it is now. How would you build the system? What do you think actually, I mean, you could tell me one or two salient ways that you think you could improve the system as is, but also, what do you think the ideal system would be?
Well, I guess one thing that I should acknowledge first, that is a flaw of the system that you sort of alluded to with your questions, but I've gotten so excited I've gone off in different directions. And Medicare is not the only funder of graduate medical education. There are other funding streams. As you mentioned, I work at a children's hospital. Other than a handful of patients of mine who are on dialysis, we don't have any Medicare patients. So we don't get DGME and IME payments that amount to anything at all, really. So for children's hospitals or pediatric programs, they need to come up with other ways. So for children's hospitals in particular, there's a separate federal program called CHGME, Children's Hospital GME, and it provides payments to those entities, which, is good. Because otherwise, like I say, if we're depending on Medicare to do these things, Medicare doesn't cover everybody. Similarly, in many residency programs, their residents spend a lot of time training at VA hospitals, and the VA pays for training expenses and a share of those costs for the time that residents spend at those locations. And again, that sort of makes good sense. State Medicaid programs often provide DGME-like or IME-like payments, but it's very variable. I mean, states like with other things related to Medicaid, they have broad discretion in how much they want to provide. And so some states like California and New York, they provide a lot and they provide very structured payments, and other states provide little or nothing. So there are other funding streams. And I guess as we get to reforms, I think that's probably one thing that probably we don't necessarily need to have in the way that it exists. If our goal is to fund residency, I don't know that we want to do that through this patchwork quilt of different funding streams that are all subject to different, pressures in Congress and lobbying efforts and things. I think we probably, if our intent with the policy is to do something else, we probably want more of a sensible across the board policy. I think probably it would require DGME-like payment, sort of a base operational payment to either hospitals or potentially the academic institution, which might make it a little bit cleaner to give the money to the academic entity that's responsible for the training rather than the hospital. Because those entities, sometimes they're one and the same, but often they have different incentives. And if the goal of residency training is educational, it may make sense to shift that funding stream to the academic institution and have them shop for training sites and have some say and control over how training, is conducted, or they can take their GME money elsewhere. Similarly, I think if the goal of funding graduate medical education is to achieve something related to our future physician workforce, then it makes sense to have incentives to do that. Congress or Medicare or wherever these funds come from, they should have some lever to encourage people to train in certain areas or to provide some benefit to society in the long run. And there's lots of different ways you could do that. And you'd have to think about what the unintended consequences of various metrics or measures might be. But it doesn't make sense to me to come up with just this, DGME and IME system when we have a very powerful lever. And we've got a $16 billion lever that we could use to move other things in a favorable direction and achieve some of the ends that we might want to. With workforce creation or with, some social good or public value that comes out of our GME funding system.
So many things to consider, so many stakeholders, the federal government, the taxpayers, the patients, of course, the residents, the hospital system, the educational system. Here at Yale, right, the residents are employed by Yale New Haven Hospital, but I, as their program director, am employed by Yale School of Medicine. So that sort of separation and, trying to balance their education and their training with the needs of the patients in the hospital and not leaning on them too much for patient care, but understanding that a lot of the patient care is where that funding is coming from. Just so many things to think about. Thank you for giving us this overview of the landscape. It's very complicated.
Yeah, we sort of only barely scratched the surface, but yeah, you're right. It's a mess. And I guess the last thing I should say is that, obviously there's not necessarily an appetite for broad reform right now, but the longer this system persists and the more deeply embedded the winners become, the harder it is to change anything. And these IME payments in particular, in matter of practical reality, they function to subsidize indigent care. And it's not the cleanest way of doing it. It's not the best way of doing it, I don't think. But if you reform this payment system, you have a lot of hospitals that are very invested in things working the way that they do right now because it would put them in real financial trouble if these payments suddenly changed. But like I say, that's not something that's going to get better just by letting it sit for another few years. I think it would be fair to provide a soft landing. As we said, it's a complicated system. It's not what any of us would design. And anyway, thank you for letting me chat about it with you a little bit today.
Well, maybe you're going to inspire some of our listeners to the advocacy pathways of careers and programs like Neurology on the Hill and those types of things. All right. Well, maybe we'll have to reconvene for a fellowship conversations at a later date, but I appreciate your time.
Hey, you're very welcome.
Neurology Nuts and Bolts podcast was created and produced by myself, Sara Schaefer. It is not recorded as an official podcast of any institution or organization. The podcast is unfunded. Opinions are those of the individual participants. Music by Audrey Nath, artwork by Shivani Ghoshal. Want more content like this? Be sure to subscribe to the Neurology Nuts and Bolts podcast wherever you get your podcasts to hear more about constructing your career in neurology. Follow us on X at NeuroBolts and on Facebook at Neurology Nuts nuts and bolts to stay up to date on new content and give us feedback on what you want to hear. And tell your friends. Thanks for joining us.